Hello everyone, Dr. Matt Ed. Today we'll talk about useful scores for chest pain for patients with unstable angina or NSTEMI, and these scores include the heart score, Gray score, and TIMI score. Some overview of the scores. The heart score predicts 6-week risk of major adverse cardiac events, and it's mostly used in the ED to risk stratify patients for discharge or admission. The Gray score estimates the probability of death from admission to 6 months for patients with ACS. However, it's occasionally used for high-risk NSTEMI patients to consider doing early invasive management as opposed to delayed intervention. This is more accurate than the TIMI score. And the TIMI score estimates the risk at 14 days of all-cause mortality, including new or recurrent MI, or severe recurrent ischemia requiring urgent revascularization. Overall, this is easier to use than the Gray score. To summarize, the heart score is used by the ED to risk stratify for discharge or admission to the hospital. The Gray and TIMI score can be used for patients with unstable angina or NSTEMI and to determine early intervention versus later. These are the components of the heart score for major cardiac events. It's scored from 0, 1, and 2, and there are 1, 2, 3, 4, 5 categories, so maximum is 10 points. And these categories include history, EKG changes, age of the patient, their risk factors, and initial troponin. Points are given based on each of these selections. The score determines the 6-week risk of a major adverse cardiac event. So scores 0 to 3 are low risk, and these patients mostly were discharged. Patients who had scores 4 to 6 were admitted to the hospital, and patients with scores greater than or equal to 7 has a high risk, and they were recommended for early invasive measures. Next, we have the Gray score for ACS and risk and mortality, and the components include age, heart rate, blood pressure, creatinine, if they had cardiac arrest on arrival, any ST deviations on EKG, abnormal cardiac enzymes, or any signs of heart failure. So the Gray score, when you plug those in MD Calc, it gives you a numerical score, and the score determines the patient's risk, either low, intermediate, or high. The top box indicates in-hospital mortality, and the bottom box indicates 6-month post-discharge mortality, and this is for NSTEMI. Usually, if they're intermediate risk or high risk, then an early invasive approach is recommended. Now we'll talk about the TIMI risk score for unstable angina or NSTEMI, and it's categorized into 7 categories, and the mnemonic is America. So A for age, greater than or equal to 65 years, markers for elevated cardiac markers such as troponin, E for EKG changes, R for risk factors, 3 or more cardiovascular risk factors, and that includes hypertension, hyperlipidemia, diabetes, family history of CAD, or a current smoker. I for ischemic chest pain, so anginal pain for greater than 2 episodes in the last 24 hours. Coronary stenosis, prior stenosis on angiogram of 50% or more, and if they're using aspirin in the past 7 days. So each of these categories gives you 1 point, maximum is 7 points. Here we have the TIMI score interpretation. 0 to 1, they're deemed low risk. 3 to 4, they're deemed intermediate risk. And a score of 5 to 7, they're deemed high risk. Patients with intermediate, or high risk should be considered for early intervention. Overall, patients with high risk should be considered for early invasive therapy, and patients with low risk should be managed conservatively. And all these components make the patient high risk, such as positive delta change in a high sensory troponin, EKG ST changes, TIMI score greater than or equal to 3, recurrent ischemia symptoms, heart failure symptoms, and prior revascularization. Low-risk patients include normal EKG, negative cardiac markers, and TIMI score 0 to 2. These are my references. If you thought this video was helpful, please like, subscribe, and look out for my next video. Thank you for watching.